great way to get things going. And then it can be research still nearly full time, so they have such a much disease. I'd be happy to talk to you about that too, and who to, or if not them, who to talk to. That type of stuff. So keep that kind of in mind, and I'm always available. Email me, call me, whatever. I'll give you all.
Then they'll be committed to my office.
They're just great for you. Just text that way. Research buttons. It wouldn't have to. I'll give them a card. Yeah, absolutely, pleasure.
No.
Did you research? Probably better than criminal.
Great stuff.
I don't think I do. I think I've lost it. I went last year as a CPM. I felt it actually comes out. Sadly.
Yeah, but
I thought I would do better.
Yes, it was a pleasant surprise.
I mean, I can
Complain about it. That's what makes everything green.
Yeah,
they have to get
sure, it just happened.
so far. Well,
It's not
so if it comes out of so far.
the
problem is
but I don't
people
cheat.
that's private practice now. They have clinics every place now. They have no money. So my own son competes against me on the east side, but he's only there. You know, I'm a 5 days a week, but
Yeah.
CW fellowship.
That's right. I remember.
But he comes over and he has an east side clinic, but he's only there like 1 day a week. They don't have that presence yet. But still, he's
Neither of them came to talk last night. They're permitted.
they're not allowed to eat. They have to pay for
Well, did I tell you I'm not supposed to be there?
You should not have brought those many donuts.
Yes.
Because I ate them and now I feel ill.
Now you feel full.
Maybe come over there to the clinics that lane, but it's on the traffic.
Yeah, we had a busy clinic yesterday.
I was just telling you, you compete with us in private practice. Like that with your Bellevue. I don't mean patients don't show up.
Somehow we found it.
So no, it's working out fine.
It's actually not
This way, right?
It's actually really.
That's what I'm saying. I have this It does say 750.
I was talking about around the country.
Steve's the one can have to tell you. One of the people there last night was the skinny Asian guy.
Yeah, maybe even say something.
But you know,
He's got rid of that.
as you know, this is probably a workplace. We talk about allergy in the United States.
I'm just terrifically studied and everybody in the practice is listed as,
But everybody trains here.
but in this case, I actually yours is zero except for Steve.
You know what happened about 8 or 10 years ago? What happened is my knuckles are caught up and all of a sudden it's choking off my finger. I didn't know it was sawed off. And it's still sitting in the drawer. I haven't got to repair it one large.
He really wanted to do
But
this.
no, I lost it.
He really wants to see.
And you know, I do
I
have
think
another
it's
one.
since then,
Five
now
like
it's
watch.
different ones like this. Some good and some bad. So it'll be.
You know what I was thinking about that?
There's always this.
I bet the belt came off. You didn't see a belt wall that well.
Nothing. Not in inflammation, but in
The belt wasn't a cage.
sometimes they think
That's why I think the belt. You were around? I was around. I
they think they can overlook
Oh,
team memory.
it's impossible.
And there's other
You know what you
things.
have to do to get, and this is why I don't want to do it. I hope part of the pull pins off.
So now we're going to look at that.
Pull it out. I did that one more.
In the body, we have kind of roots. That's a mix of what we're seeing.
He's done that with his mark. It's complicated. Why don't pull the pins out?
What's the next guy?
I thought maybe it was something.
You really don't have a maybe those are good antibodies for each other.
I went, we're going on Friday. We're going to go out there. I got to mow the lawn. I'll borrow it. It's a small one.
Industry's
It's very long.
and the NIH.
It's not too bad.
I brought you guys.
How many centers?
No, I was talking about the whole. You know that? No, because that's what I was worried about. Because on the other hand, with those little push mowers, if the grass is that deep, you know, it's a pain in the butt to mow that.
It's fairly.
So I love that big industrial mower.
And you're this.
It's fabulous.
Yeah.
But
How's the enrollment?
it's a pain in the butt when you have, yeah, because you don't have to less of that for 50. We committed months ago.
Over
And then,
a year left.
well, I'm going Thursday.
He told me he was coming back. I think he said he was only the last.
Oh, that's, well, I just need the phone.
I didn't beat on him as much as I did for the people last night, but he also.
That's good. It's always good.
So,
At least put it on the people.
How are you? Good. Good to see you again.
That's the other thing. Some people get in strike or retire. It's not worth it. I'm too lazy.
I'm like, oh my god, I know it's my kid.
It's, you know, it's painful. I dictate my notes, but I still not the EMR whole thing.
I had my father was a physician who used to see it's nice to sit and talk to a patient.
Yeah.
Try to jot down a few notes where Sam's at right now. Sometimes I go out of the room and at the end of the day try everything.
A lot of mine is that way too. So I'm looking at all the guys, you know, the guys that are doing type and stuff. Now, one of my partners does dragon. He's good at it. It takes a little while to get that down.
Does it work well though?
I think
Transcription pretty good.
he thinks it works pretty good. It's better than used to. You know, and especially
I tried one of those systems.
the cell phones work great. You know, it's amazing how good the recognition on this. Well, my dragon, I did order one about 4 or 5 years ago, or like 7 a year. It was terrible.
It's changed a lot.
You know what
Yeah, I know.
Incredibly accurate.
Yeah, I was just gonna say that the cell phones are so good that
Yeah,
they
the
all
iPhone has a
work.
great voice recognition.
And it's specialty specific now, so
You have to pay extra for the allergy, you know, don't you? This is like $1,000.
Yeah, and the initial system were
Well, I just, you know, I'm probably gonna retire in 2 years. I shouldn't ask you, but how old are you? I'm 65. 59, so you gotta keep it. I'll probably, you know, 68, I'll retire. 68. You know, I'll just go close to 70 around there. First of all, he's so nice. It's not, it's a 9 to 5 job. You don't have to commit. There's no death in that kind of stuff. So it's not a stress. So that's why.
Yes, really.
I think so too. Oh yeah, and they're basic for health first.
Well, no, I've always been. Since the very beginning.
Yeah. Well, there's no question that, you know, it's interesting. Part of our business now is everybody thinks you're going to do this. So they come and see it and say, well, I got, you feel like,
I'm a real expert. I'm on a little combat diet.
no, so it's business for us, so I can't complain.
Hey, are you exhausted?
Yeah.
Did you get in late?
Yeah, like this. Sorry.
We were gonna patch you in to the plane.
That'd be cool. I can. Audio. I don't know. Hey. Where did you be? You said just college music. Oh, you're not nervous. You're like, I was going to say, you know, like here in the, when I did the fellowship.
Are you going to clinic today?
Yeah, 9. Len sort of reminded me that.
No, I went to one. There was one in Seattle about 15, 20 years ago. So I went to, I had to get, you know, I wasn't a member. Actually, it wasn't that big.
the word of the day is Montebello. Everyone make sure they unwrap their food right now.
been getting a lot of complaints on the outside about us being really loud, so.
Isn't that just white?
That's just white.
No,
That's a lot of fun.
I was quiet.
It's like a field trip for partners.
And it's a happy occasion.
Yeah. What was San Diego? So there's about 5 of these down there. My parents were there. My parents were
Ryan, how are you, Ryan?
good. You know, my father is.
Coming to learn?
Yeah.
Hey, everybody on the wraps.
It is.
Every Tuesday.
Okay, let's stop all the background noise so I don't get phone call complaints. Well, it's really a privilege to have Jonathan Corren up here today from the Department of Medicine at UCLA. For those who don't know, we're also collaborators here on an interesting study that he's the national PI on, the so-called catnip study. Steve Tillis is our local PI on that, and I understand our recruitment's going extremely well.
Yeah, and Ryan is the reason for that. He's our stellar coordinator, gap year science guy, headed for medical school hopefully eventually. Not too soon, hopefully.
So this is an interesting topic. It seemed to me a couple of years ago this was a very hot issue. Is airway remodeling and asthma a real clinical issue? And either I'm not reading the journals much anymore, or this is not in the limelight quite as much. But to me, is still is this a real concern or not? Is really the issue here. So hopefully we'll get a definitive answer or some part thereof.
You've got more definitive questions. Can everybody hear me okay? I'm not sure if this is picking me up.
I think it is.
We're good? Okay. Well, thank you all for coming. I'm envious of those Egg McMuffins. I got here too early and I ate the little donuts. So I had a funny expression on my face during the rest of the talk, but I understand why. So we're going to talk about airway remodeling. And I think Len brings up a very interesting point, which is we're not seeing as much of this, or maybe over the past few years we have not. And I think it's a similar situation to the hygiene hypothesis, which I think was in our literature in a very bold and forward way for many years. And we realized we didn't have strategies to deal with it, so it in some way fell off of the map. And I think to some extent airway remodeling is similar, with the exception that we're now on the brink of developing some new targeted therapies that may allow us to deal with some of the implications of airway remodeling. And we're going to explore that as we go through some of this data today. So we'll be talking about, is airway remodeling in asthma a real clinical issue? So for disclosures, I do research at our site with the NIH and a number of pharmaceutical sponsors, and I've been a consultant recently to a couple of companies. So as an overview, we're going to start with a case study that I think is very, very illustrative of what goes on in a typical patient where there's long-term impact on airway function. We'll get into some of the pathologic characteristics of remodeling, some of the functional effects of remodeling, which really brings up the issue, is there clinical relevance? And then we'll finish with the effects of asthma therapies on remodeling. At any point as I'm going through this, you have questions, please stop me. And as we go through the case, I'm going to throw out some questions and would appreciate it if you do have any insights. So let's start with a case history, a real patient, who is, I think, very emblematic of many of the patients that I see as my practice sort of leans towards later onset difficult asthma. In this case, it's a patient in his early 40s who recalled having rhinitis and asthma through much of his childhood and adolescence. But as we see in many of our patients, when he reached college years, his asthma became minimally symptomatic. So through his 20s and 30s, he really wasn't bothered to a great extent, although he continued to have mild, persistent rhinitis on a perennial basis during the same time period. It was to such a limited extent that he only medicated infrequently. However, However, when he reached the magical age of 40, as many of us understand, he developed a bad cold. And following that, he couldn't shake it as he normally had. He developed a productive cough with mucopurulent sputum and wheezing and an increase in nasal congestion and postnasal drip. Nothing had he seen the likes of in his entire life. And he went back and forth to his primary care physician and received antibiotics on multiple occasions, the usual things that we typically see, starting with azithromycin and working his way up to Levaquin, and frequent Medrol dose packs. He finally got through this, but realized that his way of being had not returned to his usual. And since then, he's been treated with a variety of different high-dose inhaled corticosteroid LABA combinations. At the present time, receiving an HFA. Tiotropium was added on after several months, montelukast, and an intranasal steroid, which also has varied between aerosol and aqueous formulations. But he still reports that he needs albuterol daily and often sleeps fitfully. You can read it at the very bottom. It says, are there any additional questions that you would ask him? And certainly a lot of things come to mind. Things like environmental control measures. Is he compliant with his medication? Does he use a spacer? How often has he used oral corticosteroids in the past year? Anything else anyone would want to know?
Do the steroids help?
Steroids do help. Absolutely.
Reflux?
Occasionally.
Repeat her question.
Reflux, and the answer is occasionally.
You ever had nasal polyps?
Not that has ever been diagnosed.
No CT scan of the sinuses.
Never had one.
Sense of smell okay?
Sense of smell is a little bit impaired. So you asked all the right questions, and when I look in his nose, I see small nasal polyps, not filling the nasal airway, with some dry mucopurulent discharge. His nasal airways are patent bilaterally, and with deep expiration, forced expiration, he produces wheezing. So of course we do a spirometry, which shows he has what we would consider to be severe impairment. At 59% are predicted, and this is while taking an ICS-LABA the morning of, which is increased by 3% after a couple of puffs of albuterol. His FEF 2575 is 23%. His ratio of FEV1 to FVC is 0.68, and his exhaled NO is 32 parts per billion. Are there any other tests that you'd like to order at this point?
First, what's the upper limit of exhaled nitric oxide?
Well, the lower limit would be 25, but in somebody on inhaled corticosteroids, you expect to see it even lower while still potentially having asthma. Most of the studies report that people...
How about us? CBC.
Why don't we look? I didn't give Steve these questions before. His allergy tests show that he's allergic to western ragweed, elm tree pollen, and cat dander. By the way, he does not own a cat or a dog or a bird. And his total IG is 108. His CBC, he does not have a leukocytosis, but he has 5% eosinophils. Normal for this lab is up to 6%. And he has 360 cells per microliter of blood. And alpha-1 antitrypsin level is normal. So we have a patient who has incomplete reversibility, who has relatively significant impairment of lung function, and is being treated with near maximal therapy short of using oral corticosteroids or omalizumab as a biologic, and has very problematic asthma. One of the questions that enters in, does he have relevant IgE in this case? And in the opinion of the physician, it wasn't relevant. Doesn't have a cat, has a couple of seasonal pollens, doesn't have any exacerbation of rhinitis during that time. So it appears that clinically his disease is largely non-allergically driven. In this situation, you could make a case for an anti-IgE treatment, although I think that it could go either way in terms of outcome. So let's take a step back and look at things that we looked at back in medical school when we used to study Crayola bodies and things of that nature with reference to asthma. We have the physiologic and pathologic hallmarks of asthma. Physiologically, we're all familiar with the two things that we look at. We look at airway hyperresponsiveness, which is considered a part and parcel of bronchial asthma, and the second being reversible airways obstruction. I think many of us have gotten used to the idea that we may see airways obstruction and it may not be reversible. Pathologic attributes, of course, are airway inflammation, typically Th2 lymphocytes in most patients, mast cells, basophils, and eosinophils. And what we're going to be talking about today is airway remodeling. Inflammation referring to the cells that come into the lung, remodeling, looking specifically at the structural elements and how they change over time. When we look at the components that are involved in remodeling, there's a number of things that probably account for these permanent structural changes. Although we're not sure if they're always permanent, but we look at them as certainly progressive. Number one being the airway smooth muscle mass is increased. Secondly, when you look at the extracellular matrix, particularly under the basement membrane, you see an increase. Staining for both specific proteins like different types of collagen, as well as an actual increase in the thickness of the reticular basement membrane, what we call subepithelial fibrosis. There's a number of different blood vessel alterations, and you can see these histologically simply by looking at a cross-sectional cut of an airway and seeing in the submucosa an increase in the number of blood vessels that wouldn't be there in normal lung tissue. We then go on to epithelial alterations. Although it's listed number 4 on this list, it probably should be higher. We know that the epithelium now is such a vital immune organ in patients with asthma. And then finally, mucus gland and mucus alterations may play an extremely important role in this whole process. I think it's been pretty well decided that people don't die from asthma through bronchospasm. They die through extravasation of secretions and mucus, and they literally drown to death in their own secretions. So before we get into some of the particulars, this is an overview, some of the compartments that are involved in airway remodeling. On the left, to the left of the dotted line, we have a normal airway.
There should be a pointer. Use the mouse.
Okay, so we've got on the left, normal airway. On the right side, not very strict memory. We've got a patient with asthma that's gone through some of the typical morphologic changes. So in the upper right, we can see a blood vessel that we referred to. One of the issues, not only are there more of them, but there's increased permeability. We can look at smooth muscle down, sort of halfway down on the right. We're looking at an increase in smooth muscle mass. If we move inward to the lumen, we can see that in some of the areas, epithelium has actually been lost, separated from the basement membrane. And right outside of those epithelial cells are clumps of mucus. And if we move back away towards the adventitial side of that airway, we can see that the basement membrane extracellular matrix has actually been increased in thickness. And then we refer to a number of different cytokines and mediators that we're going to get into individually. So this is our starting point. So why are we interested in it? Certainly we know pathologically that some of these signs have been present for years, starting with the smooth muscle increase in mass. But we've identified over the past 20 years a large group of patients who have poor reversibility of obstruction and patients who have progressive decline in lung function over time. There have been some very elegantly conducted studies over 10 to 20 year periods where we see people develop FEV1s akin to what we would see in COPD. Histologic tissue remodeling may explain many of these findings. And if we can identify the likely underlying mechanisms for why you get increased mass of the smooth muscle or why you get increased mass of basement membrane thickening, then we may have therapeutic targets that can turn the time clock back. So we'll start with airway smooth muscle. We know that in patients with chronic asthma, there is an increase in mass due primarily to hyperplasia. In patients with more severe asthma, there is an actual increase in the size of the cells. This doesn't only occur in the large and medium airways, it occurs in the small airways. Wherever there's smooth muscle, we see this. And interestingly, if you look at patients with fatal asthma, the actual increase in mass goes upwards 50 to 200% over a normal patient, where in patients with more usual asthma, it's increased 25 to 55% over what we would see in a controlled population. Where do these smooth muscle cells come from? That's important, because if we're going to deal with one of the underpinnings of bronchial hyperresponsiveness, and we'd like to know why this is happening. And a lot of it may be due to resident mesenchymal cells. They're actually generating smooth muscle. The epithelium may actually be able to migrate inward and transform into smooth muscle. The the possibility of smooth muscle cells actually proliferating and going through cell division is possible, but most people don't think that's a possibility. The molecular triggers are what causes all this. Number one would be TGF-beta. And we keep coming back to that mediator as a very prime determinant of airway remodeling. IL-1 beta is important. IL-6 is probably important. Leukotrienes are very important. And I know Bill Henderson has done a lot of work looking at the role of leukotrienes in remodeling and whether or not if you block them, you can actually spare remodeling in a mouse model. But smooth muscle not only dictates the confines of the airway, but it's an active immune organ. And this is something we've come to realize just in the past few years, that the smooth muscle makes IL-1, makes IL-6, IL-8, which is very important to neutrophilic asthma, and prostaglandins like PGE2. And the airway smooth muscle actually makes the extracellular matrix proteins that support it. And people wonder, why do we even have smooth muscle? Why do we have remodeling around it? One of the teleologic arguments is that if you develop extraordinary hypertrophy and hyperplasia in a severe asthmatic, if you didn't have fibrosis in the adventitium around it, there might be no way of supporting it. You'd have complete airway collapse. So that may explain why you have the remodeling around it. But a more even basic question is, why do we have smooth muscle? Many people have argued that it's a leftover. It's a vestigial from our years of probably living in swamps where we had to expel parasites when we were exposed. And right now, perhaps they don't play such an important role. But I think that question remains to be answered. And if we look at hyperplasia, this slide shows with the arrows the myofibroblasts, and it shows the reticular basement membrane under the epithelium at the very top. And if you look towards the center, you see the airway smooth muscle. We don't have a normal comparing this. I have that later on in the presentation, but it gives you an idea that there's a lot of smooth muscle underlying the submucosa and epithelium. So we talked about severe asthma and the role of airway smooth muscle, and this was a study that was done. They actually took biopsies from patients who were both normal and in mild, moderate, and severe asthma, as well as COPD. And if you look at the airway smooth muscle size in this slide, your attention is drawn to that fourth group of dots from the left, where we can see that there is a significant increase in patients who have severe asthma. Now, that is not to say that you don't have hyperplasia in patients with lesser severities of asthma, but where you actually see this increase in mass, or excuse me, this increase in size contributing to the mass, is in patients with the most severe degree of asthma. So if we move outward from the underlying smooth muscle into the extracellular matrix, part of normal mesenchymal cell function is to regulate this matrix that surrounds the airway that we've talked about. And what is in this matrix? It's a big question, because if we're going to target some of these things, we'd like to know exactly what are the constituents: proteoglycans, different types of collagen, elastic fibers, and there's a group of non-proteoglycan glycoproteins, which include fibronectin, laminin, and tenascin. The reason I mention these is because many of the studies that look morphologically and microscopically at the airway to determine is airway remodeling present or not actually stains for these specific proteins. We've talked about the provision of structural as well as biological support to the airways. And a very important mediator in this whole process, what we call matrix metalloproteinases. And there are a number of them. We think they come from neutrophils as well as other cells. And this balance between MMPs versus tissue inhibitors of metalloproteinases, the TIMPs, are really what regulate. Are you going to have an increase or a decrease in the connective tissue around the airway? We don't fully understand the nature of this balance, or the role of these MMPs in regulating remodeling, but suffice it to say that when you go down in an asthmatic, particularly with severe disease, and you bronch them, you find a lot of these. And you also find the TIMPs trying to counteract them. In asthma, we know that the extracellular matrix is increased, that many of the collagens, but not all, are increased. So you have type 1, 3, and 5, and you have an increase in these other proteoglycans, fibronectin, laminin, tenascin. There's an increased thickness of the lamina reticularis, which we refer to as the reticular basement membrane, which underlies the entire epithelial structure. And you end up really with fibrosis. So asthma, when it's been around long enough, is a fibrotic disease. And the main mediators that control the synthesis of these proteoglycans and non-proteoglycan glycoproteins are TGF-beta, which largely comes from eosinophils. So as you start to think about new drugs and how they inhibit eosinophils, you see that perhaps we can actually modulate TGF-beta. And changes in the balance of the MMPs and TIMPs. And we've talked about this possible protective role of developing fibrosis as smooth muscle continues to get bigger and bigger in size. And if we look at patients who are normal, who have moderate asthma, and who have severe asthma, and we look at the thickness of the reticular basement membrane, you can see in the far right that without doing any kind of measurements, there's a gross increase in the amount of this connective tissue underlying the epithelium. And if you stain for type 3 collagen, we've talked about the importance at a scientific level of trying to identify what are the proteinaceous constituents and what do they look like. You see an increase in collagen type 3. And in this case, it's staining blue, and you can see it scattered throughout the airway to a much greater degree than you would see in somebody who doesn't have asthma. And then finally, we'll end with this idea that TGF-beta1 is important. What we're looking at, again, is a bronchoscopic study where we're looking at positive cells per millimeter of the membrane. And what we're looking at are 3 or 4 different groups of patients: normals, starting at the far right, then mild asthmatics, moderate asthmatics, and severe asthmatics. And we're looking at, you can see defined by the legend, TGF-beta mRNA. We're looking at EG2 positive cells, which would represent eosinophils. And what stands out is that as you go upwards in the severity ranking of the asthma, that you get a lot more eosinophils, you get a lot more TGF-beta1. If you actually stain these cells in a separate experiment using in situ hybridization for TGF-beta, you see that the eosinophils are one of the prime sources for this. So as our wheels turn internally, we start to make a very good case that if we can inhibit the eosinophil for a number of different pathways, that we may have an effect on TGF-beta and hence airway remodeling. We started by touching on blood vessels, and there are really 3 changes that the submucosa goes through with respect to blood vessels. Number 1, you get angiogenesis. Same type of thing that we see in tumors. You see an increase in blood flow to the submucosa. You see an increase in blood flow through those new vessels, and you see an increase in vascular permeability. This becomes very important because you start to build an idea that we can have swelling of the airway, and that swelling can contribute to potentially airway obstruction. The things that control angiogenesis are many, but I'm going to touch on the number 1 source being vascular endothelial growth factor. We hear a lot about VEGF, and this is what it is. It comes from Th2 cells, which are prominent in Th2 asthma, but also from eosinophils, from macrophages, and even from the airway smooth muscle itself. Increases in permeability are regulated by things that we routinely see in allergic asthma, from mast cell degranulation, an increase in histamine, an increase in leukotrienes, and again back to VEGF. So VEGF has a huge impact on the vasculature of the airway. And there have been attempts to look at VEGF inhibition in animal models, and it seems to have a salutary effect, at least on what goes on at the microscopic level. I'm showing you this, which is about a 25-year-old picture from what was once called the American Review of Respiratory Disease. And it's interesting because it gives us a very dramatic interpretation of what this blood vessel plexus looks like surrounding the airway, both arterioles and venials. So you really have this very vascular mesh. So any changes in this, that increased blood flow or changes in vascular permeability, will have a tremendous impact on airway function. And then finally, we'll look at increase in angiogenesis, and you can see these blood vessels. They're large, they stain clearly, and I will tell you that to see this many in a typical cut is abnormal. So now we'll move on to something a little bit different. We'll come back up to the luminal side of the airway and talk about the epithelium. And we know that the epithelium plays an important role. It separates the environment from the internal workings of the body, very much like the skin. And what the barrier function relies upon is effective cell-to-cell adherence through tight junctions, and gap junctions. any kind of a failure in this is going to lead to increased permeability through the epithelium to dendritic cells. I can see my slides, you just can't see my slides.
Things were working too smoothly.
I know.
But this is an option to unwrap.
You got through half the talk.
Yeah.
Is that enough?
No, you have to finish.
Let's see if they're.
So I'm going to talk about barrier function, because we don't need the slide for that. And what's interesting is what we've kind of realized over the past few years is that allergens that we inhale on a daily basis, particularly fungi and dust mites, have proteases that break down these gap junctions and actually enhance the penetration not only of those same allergens into the subepithelium, but allow other things like pollutants to make their way in. So when you look at the barrier function, it's the first step before you invoke the immune function of the epithelium. And I can make some sort of general comments about the epithelium as an immune organ. Number one, it's extremely active. And I think all of you know from recent readings that at one time we thought the epithelium was passive, at the very best acted upon by other cells, but now we realize that it's really the first initiator of what ultimately ends up being type 2 immunity or Th2 immunity, allowing allergens to set up a whole sequence of events. Are many of you familiar with pattern recognition receptors, which has become, I think, a very important area of research? And the so-called PRRs are activated by pathogen-associated molecular patterns. I'm going to talk to this because the slide isn't really helpful. What are called PAMPs or PAMPs. So one of the areas where we see there being very fruitful research is the interaction of both pathogens and allergens through these receptors interacting with these very set molecular patterns. Okay, so we're down to bullet point number 3. One of the principal receptors for this are the toll-like receptors, particularly 1, 4, and 9, that exist on epithelium, and first interact with a virus, or interact with mycoplasma, or interact with allergen, and allow that antigen to be transported through the epithelium to a dendritic cell, and ultimately you end up with type 2 immunity. And I think this is a nice cartoon that shows the epithelium plays a very important role in activating this Th2 skewing that we see chronically in patients with allergy. And if you look up at the top of the lumen, you've got allergens, you've got helminths, you've also got other pathogens that are floating around, and you've got the epithelium. And there are a number of epithelial cytokines that are now extraordinarily interesting targets for potential therapy. IL-25, IL-33, and TSLP, thymic stromal lymphopoietin, which Len alluded to, that has become a very active target for research as a regulator of the immune system. So you've got these epithelial-derived cytokines, and if you look at the far left, you see a dendritic cell, the one with its arms and legs sticking out, which then becomes polarized as it presents that particular antigen to a naive Th cell. So the dendritic cell grabs hold of the allergen, it migrates into the local lymph node. The lymph nodes are extremely important in this regard. And you have presentation to a naive T cell, which then, through the polarization by the TSLP or the other epithelial cytokines, causes that Th cell to become a committed Th2 cell. At the same time, you've got epithelium, through these epithelial cytokines, activating innate lymphoid type 2 cells. And it's because of those ILC2 cells that everybody can see in the middle of their field that we now call it a type 2 immunity rather than Th2. Because even before you have the involvement of IL-4, 5, and 13, you can have activation of these innate cells simply through the epithelial cytokines. And we believe that's what gets the ball rolling in part. And we believe that's how you can have, through the role of IL-5 and IL-13, eosinophilia, without necessarily having a lot of IgE, which we're now seeing frequently in studies, that we have a type 2 asthma in the absence of specific IgE to specific allergens. But in any event, you get what we now have are the classic Th2 cytokines. You've got 4, 5, and 13, and to a limited extent 9. And you start to get eosinophils, and you get plasma cells becoming IgE producers, and then you have a complete picture of atopy. The alterations that we see in asthma are, first, we know these cells slough. We knew that back in the 1920s, that when people coughed sputum, there were more epithelial cells. We didn't know if that was real, if it was an artifact. Biopsies showed that there was a separation of epithelium from its underlying basement membrane, but we now know this is real through open lung biopsies that have been done. It's inherent to asthmatics. There seems to be a flaw in these tight junctions that are adhering to each other and to adhering to the basement membrane. But to a large extent, there's a secondary effect of inflammation. And we know eosinophils with ECP and MBP and all these horribly toxic cationic proteins can move the epithelium away from its anchor. That's number one. Number two is we know there's an effect on viral immunity. Because you get an impairment in apoptosis of the epithelium, in other words, you would like this epithelium that's infested by influenza B or by rhinovirus 16 to just die. But if it doesn't die, it gives these cells, these viral particles, a chance to perpetuate, for the infection to persist, and for it to eventually worsen. And then number three, we know that in asthmatics, there's a defect in wound repair, and that this defect allows an increase in TGF-beta to be secreted, which takes us back to other arms of the remodeling sequence. This is a typical electron micrograph, and if you look to the left, you can see nice, thick columnar epithelium, and if you look to the right, where the arrow is, you don't have a whole lot there. It's been lost. And then we come to mucus. We know airway mucin comes from a couple sources, from what we call goblet cells, which are actually luminal secretory cells. They have a gene for mucin 5AC, and we know we have submucosal glands. Larger glands that are in the submucosa, large airways, has a different gene, which is the MUC5B. So you've got two different genes. There are about 20 different genes for mucin. These are the two that seem to be most relevant to asthma. And the main mucus-related abnormalities in asthma, which are many, are you see an increase in both secretion and viscosity. Why viscosity? Because it's literally a pool of proteins in cells and proteoglycans and all kinds of things. We see an increase in goblet cell numbers and size. This actually leads to more crowding of the airway. On top of the hyperplasia and hypertrophy of smooth muscle cells, you now have large goblet cells pushing their way into the lumen. There's a decrease in ciliary function. And then finally, we come back to hyperviscosity. And some of the factors that seem to be most important, IL-9, IL-13, is extremely important, and IL-1 beta and TNF-alpha. If we look at another histologic slide, you can see a lot of staining in goblet cells are all over the place. And if you look at mucus in the airway, we can see the cartilage, we see the muscle, we see the fibrosis, but we also see a very large airway plug. And as I mentioned earlier, this is really what gets asthmatics into their ultimate trouble, is they stop their VQ matching and they stop oxygenating. But there's something else interesting. Not only is the inflammatory milieu of asthma helped create this whole world of airway remodeling, but there are physical forces that we now have come to realize, probably in the last 3 to 4 years, that play a very important role in some of these chemical messages. It can be cough, but more importantly, it can be bronchoconstriction, which you actually have are compressive forces, which put stress on the airway. And these ultimately have an effect on the constituents of the epithelium, the fibroblast, the smooth muscle. And it ultimately leads to an increase in extracellular matrix and airway smooth muscle hyperplasia. So that sounds all good and well, but it even acts more promptly than you could ever imagine. And this was very nicely shown in a study about 4 years back in the New England Journal of Medicine. And at the top, we can see the study schematic, which is patients come in, they have a bronchoscopic exam for a biopsy, they then get an allergen challenge, 3 consecutive days, or they get methacholine on 3 consecutive days, or they simply get saline. And then we can judge to see whether the immediate effects of methacholine as a smooth airway constrictor actually can influence airway remodeling, not only chronically, but in a very short time frame. So on the left, what we're looking at are the eosinophils. And if we look, we can see that allergen, which is labeled on the far left, versus then methacholine, albuterol methacholine, and then finally saline. Allergen was the only one to up eosinophils in the BAL fluid. not surprisingly. We know methacholine doesn't cause inflammation. But what does come as a surprise to us, if we look at epithelial TGF-beta, that they were able to collect from the bronchoscopy, that you can see allergen caused an increase. We're looking at the middle graph. But methacholine caused an increase after 3 methacholine challenges. And we see that methacholine with albuterol completely abrogates this biochemical signal to have an increase in TGF-beta. And if you now take it to its ultimate final conclusion, which is morphologically, do we see an effect of these changes in TGF-beta? And the answer is on the far right, yes, we do. Allergen causes an increase in reticular basement membrane thickening. So does methacholine after a period of just several days. But with the abrogation caused by albuterol, we don't see it. And then finally, saline on the far right doesn't cause it either. Which again starts to make things click. Can we use bronchodilators to prevent some of these things? And the answer is probably yes. What are the functional effects or the consequences of airway remodeling, which is our next area of concern? Well, airways hyperresponsiveness is largely dictated by the chronically remodeled airway. But the increase in airway smooth muscle mass seems to lead mechanically to an increase in shortening, in the velocity of shortening of that smooth muscle, which is geodesically arranged around the airway, so that you have any 2 points is the shortest path. If you look at a geodesic dome, that's how it works. If you have 2 points in the structure, you don't go like that, you go right between them. And that's how the smooth muscle is arranged around the airway. That you have attachment points, and you may have it going this way, and this way, and this way. And for that reason, you can get a lot of shortening due to a stimulus. But we also think that the reticular basement membrane contributes by changing the compliance of the airway. But to a much greater extent, it's the smooth muscle. What about the other consequence of airway remodeling, which is persistent airways obstruction? We think this is due primarily to big, fat, smooth muscles. But we also believe that blood vessel permeability probably plays a role through this whole issue of vascular leak into the adventitia. Let's talk now about the nitty-gritty, the longitudinal changes in pulmonary function in patients with asthma. This is the link we've been waiting for. This is what defines the relevance of remodeling as an important pathophysiologic process that may require increasing attention, and I think attention that it's going to receive because of these new drugs. A small number of studies have actually followed lung function in a range of sample sizes, from 80 to 90 patients up to several thousand, over periods of time from 5 to 15 years. Suffice it to say, you have to have a lot of patients to be a student and a researcher into airway remodeling. And the studies have primarily compared asthmatics versus normal controls, as well as groups of asthmatics who segregate into rapid versus slow decliners in lung function. Some of these studies have gone so far as to utilize markers of inflammation, primarily relying upon sputum eosinophils. Rarely do they use a bronchoscope to evaluate coexistent inflammation. And as I mentioned, very few studies have used biopsies. What are the caveats of these kinds of studies? Number one, you're capturing a few lung function points over long periods of time. So if you really want to iron out any of the variability, you do need large numbers. Number two, when we're talking about remodeling, we never want to look at pre-bronchodilator FEV1. We want to look at maximal bronchodilations. We've ruled out the effect of immediate bronchospasm, so we can say that this is a structural issue. But what we do often in practice is if we see the patient that we had seen earlier with 59% FEV1, and we didn't see any reversibility, and he hadn't ever been on steroids, and he was moderately symptomatic, we might do a short steroid trial. This has been advocated in the literature. Sometimes we do it, sometimes we don't, to really determine what is the ceiling of pulmonary function when you remove some of these inflammatory components. You're certainly not going to undo long chronic airway remodeling with 7 days of prednisone. So you'd like to know, is that 59% really 70% after a week of prednisone? Now, one of the things we realized, and this was from New England Journal of Medicine about 17 years ago, when they took a huge group of non-asthmatics, over 12,000, and compared them with a very large group of asthmatics, about 800, and we're looking at the left at females and the right at males. Both of these are non-smokers. We see that in the aggregate, the airway function declines faster in the asthmatic than it does in the non-asthmatic. This was really a hallmark paper that came out nearly 2 decades ago. If you also look at the smokers, it's significantly worse. We're not going to, that isn't the purpose of today's talk, But the issue is that a universal phenomenon, since we know all asthmatics have some component of microscopic remodeling, do all people have a rate of decline that's worse than the normal control patient? What we do know is that this is a phenotypic characterization, that there are people who have a rapid decline and others have a much lesser decline, much closer to the normal. And this is a paper that came out in the European Respiratory Journal, again, nearly 2 decades ago, a small sample by most measures, a little over 90 patients, but followed for a long time, for 10 years. They were able to determine that about a quarter of these people had non-reversible airways obstruction, defined as less than 80% post-bronchodilator FEV1 and less than 9% reversibility with beta agonists. And if you look at some of the characteristics below, you can see on the left that NRAO patients had a enrollment, a percent predicted FEV1 of 77.6. Everybody see that? And if you scroll down a couple of lines, you're now down to 57% after 10 years, versus the larger group of patients who started off at 89% and were down to 83% after 10 years. Not normal, but much closer to normal. And if we look at the actual scatter plot, looking at the left, which are the patients who have the non-reversible versus the right is the reversible, what we realize is that the slope of the mean line for those two groups is vastly and statistically significantly different. So when you look at these large populations, to some extent it's being driven by a subset. Not all asthmatics will have dramatic remodeling. Also, look, what you can gather from this data is that the people who remodeled the most started off the lowest. And if you look at some of the characteristics, they had the most reversible airways disease at the beginning. Their degree of bronchodilator responsiveness was higher than the people. And one of the caveats presented by this study was when you see people who have low FEV1 and are very reversible, they may be the ones who go on to remodel the most. So now let's get into, I think, progressively more interesting things. That is there a relationship now between inflammation and lung function? We're not making the leap yet to microscopic remodeling. We're simply saying, if you've got a lot of inflammatory cells, particularly eosinophils, will this affect lung function? And here we're looking at Ten Brinca, who's written a lot about severe asthma, and this was almost 15 years ago. 132 patients with chronic asthma, about half of them had this irreversible airways obstruction. And we're looking at a risk analysis for what particular predictors were most important in determining who would develop persistent airflow limitation over a long period of time. And it turned out sputum eosinophils are greater than 2%. The chances of having persistent airflow limitation were 7.7, a high degree of methacholine or histamine reactivity, 3.9, and adult onset of asthma, 3.3. Those are the three factors that were statistically significant. Everything else, the NO, the blood eosinophil count, sputum neutrophils, were not important. So we're building the case that eosinophils lead to persistent changes in lung function.
I'm just interested with mepolizumab coming on the market. If you go back to that slide for a minute, and we're going to use blood eosinophilia as a marker as to who put on that drug. We may have the wrong marker.
I think if somebody has elevated blood eosinophils, it's a fairly specific marker, but it's not extremely sensitive. What you'll do is probably miss patients who could benefit from the drug, potentially. If you have, in most of the studies, the predicted value of a blood eosinophil count is reasonably good at predicting sputum, but a low blood eosinophil count may not necessarily potentially miss people who have sputum eosinophils. And this is really, I think, controversial and it varies between studies. But if we now look at the issue of taking the next leap, which is sputum eosinophils or inflammation, engendering airway remodeling microscopically, as well as a decline in FEV1, what we're looking at here in the far left is the log of sputum eosinophils versus basement membrane thickening, the very far left. We see a relationship. We actually do see a correlation coefficient, which is not half bad, nearly 0.7. And if we now look at the log of sputum eosinophils, and we look at three different groups of patients, asthmatics in remission, asthmatics with a slow decline of lung function, and asthmatics with a fast decline, we see that in those with a faster decline, there are higher levels of eosinophils, although there's quite a bit of scatter in this data. And then finally, if we complete the story and look at sputum eosinophils on the y-axis in the far right-hand graph, and look at FEV1 decline in terms of milliliters per year, we again see a statistically significant relationship with an R value of over 0.5, showing that the higher the eosinophils, the more the decline. So these are very interesting studies, which I think shed a lot of light. But as we move forward in time, those studies were all from the late 90s and early 2000s. Now we're into 2014. And we're looking at a British study published in JACI last year that looked at 97 patients who broke down into 3 different groups. They were followed with sputum eosinophil measurements over a period of 5 years. And what we're looking at is cluster 1, who are really non-eosinophilic and have very low variation of their sputum counts. Let's look at that on the left, and then look below at how much milliliters of FEV1 they lose per year over a period of 5 years. And you're at about 14.0, which in most studies would be considered very close to a non-asthmatic patient. If we now go to cluster 2, and you can see that's an exciting group, because their eosinophil counts over time are up and down. So we're seeing people normalize, potentially with therapy. Then they have some trigger that causes a brisk increase in eosinophils, a swing in blood eosinophils, which fuels the pulmonary compartment, leading to an exacerbation. And if you look now at the loss of lung function there, it's negative 40.9 mLs per year. And now we look at patients who are persistently eosinophilic with low variation, and we have a lesser degree of lung function loss at minus 19.2 mLs per year. And I consider this to be one of the more important papers in the last year. That it's these swings in eosinophils, at least that we're collecting from the lumen of the airway, that is predictive of loss of lung function, predictive of exacerbations, more so than people who are persistently eosinophilic and don't have these radical changes. So when you have people who are at 700 eosinophils and they haven't exacerbated in the last 2 years, that this is a particular phenotype and a particular cluster that may do well over time. This is a patient that actually has a lot of exacerbations. This was taken from one of the European papers by Dr. Bai from about 15 years ago. And this particular patient is tracked over a period of 35 years, which is, I think, an accomplishment unto itself. And we're looking at recurrent exacerbations, and we're looking at FEV1 over time. And we can see that FEV1 drops, comes up, drops, comes up, drops, comes up. But at the end of the day, they've lost 50 to 70% of their lung function. And I think most of us see these patients, non-smokers in their 60s and 70s, who have FEV1s between 30 and 40% are predicted, who may still have some component of reversibility, but it's not normal. And they may or may not have active indices of eosinophilic inflammation. And then what Dr. Bai did, the same author who showed us that last case report, looked at a group of patients. About half were considered to be infrequent exacerbators, about half were frequent exacerbators. And we're now bearing down on this issue, not of just eosinophils, but actual exacerbations. And we're seeing the people on the left who are infrequent have a much lower incidence of loss of lung function. And we're looking at annual decline in FEV1. And as the number gets bigger, the loss is bigger. Statistically and I think clinically very different from patients who have frequent exacerbations. And I'm going to end with a study by Paul Laverne. Before we get into a very brief discussion of therapy, this was the START study that was published in 2009 in this form. Previous reports came out, a very large study, about over 3,500 patients in a placebo group versus budesonide. The adults got 400 micrograms a day. And what he looked at were severe asthma-related events and systemic corticosteroid use. The idea of the study was to try to determine, over a 3-year period of time, did regular use of inhaled steroids stop exacerbations, and did they have an effect on long-term lung function? So if we look at the left-hand side, we're looking at the change in FEV1, and we're looking at patients in clear who had no systemic asthma-related event. In dark, we're looking at those who had it, and we're looking at budesonide, that we can see that in both of those groups, that there's no real difference between those who had systemic events and those who didn't. But if we look at patients who got placebo, we can see that those who had a systemic asthma-related event actually has an accelerated loss of lung function. Those who did not have a systemic event do not experience the same loss in lung function. And I think in a very large, well-designed study format, this probably is the ultimate proof that exacerbations lead to loss of lung function, mimicking what we saw in that individual case, and I think giving us the idea that stopping exacerbations may be the single most important intervention in preventing long-term airway remodeling. What are the effective therapies? Well, studies in humans include inhaled corticosteroids, one study using anti-IgE, omalizumab, and one study using anti-IL-5, mepolizumab. Studies that have used in vitro and animal models, we have montelukast from your own lab here at the University of Washington, very elegantly demonstrated that a leukotriene modifier could block some of the indices of remodeling, but it's never been shown in humans. Tiotropium similarly, we've got a lot of good in vitro data showing an effect on smooth muscle, but never shown actually in humans through biopsy studies. So let's come back to the drugs that we do have. What do inhaled steroids do? Well, we saw from the START study from Dr. O'Byrne that there is an effect on reducing exacerbations. And there is an effect on blunting this loss of lung function that occurs over as short a period of time as 3 years. But when we bear down on some of the histologic changes, there have been many studies looking at reticular basement membrane thickening. The majority of studies, 5 of the 9, show an effect with therapy, giving them for as short as 6 weeks, for as long as 2 years, with doses of fluticasone equivalent from 250 to 750 BID. And these studies do show small but statistical changes in reductions in reticular basement membrane and a reduction in some of these proteinaceous constituents. But overall, the effects are very small and not consistent, which behooves us, I think, to look for even better treatments. Omalizumab, or anti-IgE, was looked at in a very small group of patients, 16 on active therapy, 14 in placebo for 4 months. And what they measured was what is now considered one of the morphologic equivalents of airway size, which is using a precise definition of airway mass using computed tomography. And if you look down, you can see we're looking at wall area over body surface area in the left-handed set. In the right set, we're looking at wall area as a percentage of the airway. And we can see that with omalizumab, that there were actually statistical changes, more so looking at the indicator of wall area as a percentage of the airway with omalizumab. And we're looking probably at a 30% reduction over a 4-month period of time, which is rather rapid. So there is reason to believe that in allergic asthmatics, antagonism of IgE may have an effect on remodeling. And if we now look at one of the more recent therapies to emerge, which is the anti-IL-5 antibody, in this case we're looking at mepolizumab. Let's take a step back. We know that IL-5 is the principal regulator of eosinophil proliferation, of differentiation, of maturation, getting out of the bone marrow and ultimately up to the lung tissue. It doesn't get the cells into the lung, but it gets them to a point where they can enter the lung. So you can look at IL-5 really as a hormone. It's systemically born, and it goes all the way to the bone marrow and causes the release of these cells. In a biopsy study of 24 patients with mild asthma, they stained the extracellular matrix, they stained inflammatory cells, and on the left what we're looking at is thickness times density using mepolizumab on the left versus placebo therapy on the right. And you can clearly see a reduction in basement membrane thickening. And if you now look at the fluorescent staining using an anti-collagen antibody, what you can see is on the left, normal. In the middle, the asthmatics before therapy, and on the right, asthmatics after therapy. And this is, I think, very emblematic of what was seen across the patients, which led to this statistical association. So clearly, anti-IL-5 does have an effect. So what we've gone over today, and hopefully some of this information is new to all of you, that airway inflammation, particularly what we call Th2 eosinophilic inflammation, seems to modulate many of the processes of airway remodeling. That airway smooth muscle constriction, independent of inflammation, plays a role through these mechanical stresses induced on the organ, which then has a release of biologic mediators that affect the basement reticular membrane and other portions of the airway. ICS therapy, while very good symptomatically in probably 60 to 70% of our patients, doesn't have a long-term effect in many of the studies that have looked at this, although I think certainly from the START study, there seems to be, because of a reduction in exacerbations, you do see a reduction in remodeling. So while there may not be an acute effect on actual protein synthesis and some of the other things you see, there may be an indirect of steroids. By blocking exacerbations by 60 to 70%, you prevent the release of many of the things like TGF-beta coming out of eosinophils that ultimately lead to an increase in reticular basement membrane thickness. And I think a number of new therapies, including inhibitors of type 2 cytokines, like IL-5, we didn't talk about IL-13, there's no data on it yet, but what I suspect is, in my closing remarks, is that this will probably be a very exciting area of exploration, because as we went through our slide set, we saw that so many of the individual processes of remodeling are controlled by IL-13. So many of these new anti-IL-13 antagonists, like lebrikizumab and dupilumab and tralokinumab, will probably be areas of active research. So in the next 10 years, you may see a big improvement in asthma exacerbations. Thank you for listening.
Why is it that the group with persistent eosinophilia does better than the group with variable eosinophilia? Is it the second point here that they're not suffering recurrent constriction and relaxation?
They have blood they have sputum eosinophils. We know that the cells are getting into the lung. And from that point forward, we're not sure. I think you have to speculate. So one of these speculations is that when you bring these cells in acutely, that they're hyperactivated. So that they're releasing leukotrienes, they're releasing TGF-beta, they're releasing lots of ECP. As opposed to sort of this chronic patient where there's a steady state, the level of activation may be lesser. So that they're walking around with blood and sputum eosinophils, but you're not getting this rush of potentially hyperactivated cells swinging in. And it clearly represents a phenotypic difference. It most likely represents a biochemical difference. It may be some of the things that activate these eosinophils coming from Th2 cells in epithelium may be downregulated chronically in these people. And so what you're left with, at least in a larger sense, is swings of these cells in and out of the lung compartment. Seems to have a much more deleterious effect. The mechanisms for that, we don't know yet.
Other questions, Frank?
Based on that slide, you showed the, if you will, protective effect of albuterol with the methacholine and all. I'm curious, since the O'Byrne study, if anyone's added a third component, like looking at adding LABA to ICS, is that better than ICS alone?
You know, I looked for that data, and the only thing I saw was Symbicort was used to look at changes in neuroremodeling microscopically. But there was no division. So in other words, they only had Symbicort or placebo. So there was no steroid plus.
It's unfortunate they wouldn't, because obviously they have this huge amount of data for safety that everybody's looking at.
Right. I agree.
And it makes you think maybe we're, based on other parameters, under-treating people, which is, sort of makes sense psychologically, but maybe we're doing them a disservice in the long term.
I think the fact that the exacerbation data, the larger the meta-analysis you look at, the more of a reduction there is in exacerbations. You add a LABA. Certainly it doesn't seem to be an adverse safety signal. If anything, there's a reduction in exacerbations, and that may speak to the fact that you are having an effect on either smooth muscle or reticular basement membrane, and maybe reducing airway hyperactivity over long periods of time. Steve?
I actually have two questions. One has to do with the real world severe asthma in our practices. If patients have not been on a biologic yet, do you think like the magnitude of the total IgE would influence us more, or the eosinophil level? That's one question. And the second question would be, thanks to Teal and Ryan, at ASM we can now get really good sputum specimens and do sputum specimens, which was not the case when we were doing a half dozen specimens 10 years ago with the new sputum. And that seems like a superior, marker of eosinophilic inflammation in the lung. And do you think there's any practical way of becoming a resource, not a profit center, but just a resource if they're either on the borderline or below, and whether we might have any chance of getting the biologic paid for if there's like 3 or 4% EOs.
I think that the peripheral blood markers are probably not a bad surrogate for that. In other words, if you have a severe asthmatic, they fail ICS-LABA. And let's say short of getting a sputum eosinophil count, if you have a blood eosinophil count of 300 to 400. And by the way, we're talking about 300 and 400 as boundaries, but some recent evidence from Prescott-Woodruff's lab at UCSF suggests that you'll have Th2 cytokines with blood eosinophil counts as low as 230. So we probably are overstating the necessity of having these very large quantities of eosinophils in order to qualify as a Th2 asthmatic. But when you have eosinophils and you have NO, which is at least a good marker of IL-13, and when you have IL-13, you're going to probably have IL-5. And there's very few patients where there's a discordance between NO and sputum or blood eosinophils. And then you're going to have periostin, which is another IL-13 marker, and dipeptidylpeptidase 4, which is another IL-13 marker. So I think with those markers and the clinical picture of the patient, I don't think, other than for research purposes, you probably absolutely need to get a sputum eosinophil count. I think it's better, but the patient story sort of tells itself. If they've been on prednisone 4 times, you're pretty sure it was due to asthma and not vocal cord dysfunction, which is pretty common, actually.
Yeah, that's true, right?
Then I think you're dealing with, and you have a surplus of these Th2 markers. I think you're in pretty good ground. So you ask the question, do you worry about EOS or do you worry about IgE? I think part of it's the patient's history. If you have a really atopic patient, I think IgE does play a role independent of the eosinophils. We know that for exacerbations in children, it's IgE on the dendritic cells that prevents those dendritic cells from becoming efficient viral killing machines. And if you can get rid of those IgE from dendritic cells, you restore antiviral immunity, which is why kids in the inner city asthma study did so well. The working hypothesis is independent of allergy. That you get rid of IgE, they get rhinovirus in the fall, they can now handle it without the release of TGF-beta and all these other bad cytokines that ultimately cause an exacerbation. So I think part of it is history, but a very atopic patient, keeping in mind that the people that do best on omalizumab are people who have elevated IG, or elevated eosinophil, elevated periostin, elevated NO. So if you have that atopic picture going on, I think there will obviously be a strong role for omalizumab in the non-atopic patient with lots of eosinophils, which I think is a different patient. And I think what the makers of the anti-IL-5 antibodies are studying a different group of patients. I think they're less atopic to a very great degree. They have more in the way of nasal polyposis and sinus disease. And their blood eosinophil counts, I mean, I have a whole bunch between 600 and 1,000 without any fungus. And they're really not very atopic. They're like this guy that I showed you. Ragweed and elm and cat. That's not allergic asthma.
Right.
Versus the patient who has had allergy, but they're in cluster 4 of Windy Moore's scheme. They've got bad rhinitis, they've got bad asthma, they've got lots of IgE, they've got lots of positive skin tests. And, my impression is those are the people that do well in omalizumab. So I think there's going to be a very important role for both of these. And the question is which group of patients is larger? Probably more of the allergics. When you look at these hypereosinophilic, really bad asthmatics that Flood Page studied and Haldar studied, in the New England Journal of Medicine, those are more, older adult patients. They're probably the worst patients we have, and I think, mepolizumab will be something we can offer them. Any other questions? If not, thanks for listening.
Hey guys,
take some food for the road, I can't leave it in this.
Over the next 10 months.
Yeah, but now that we are restricted, slowly. Exactly, yeah.
Okay. If we can do 20 to 25 each study, will finish.
Or two. I can do it.
I'm doing it. Hey, good to see you.
I don't know if you met Dan.
I did. They told me he's going to do it. Yeah, that's awesome.
Yeah, so it's really made it done.
Hi, Theo.
Oh, hi.
I even too. We always like email back and forth. You got to do something.
I'm honored to have you.
Oh, thank you. It's an interesting time.
There's a lot of data, and it kind of goes all over the place. You got to try to make a coherent story out of it.
Brian, you going up?
Yeah, the thing that always perplexes me about remodeling is that a lot of people seem to start with remodeling. Like in those studies of kids, like a pretty large portion is that normal one.
60% when they're 10.
Yeah, right, exactly. So they're not making
We're doing it.
I was looking at that. There's a really good, it looks like there's a strong link between RB16 and these MMPs.
Right.
So I wonder if that, and I wonder if that's not the same thing with also in adults. You get a bad cold, for some reason, something drives up the MMPs that start to remodel.
Yeah.
There's unusual mucosa.
Something maybe in that range.
Makes sense.
I'm not.
Right. Oh, I think definitely. And probably the same thing for exacerbations. There's something.
But when can we mature?
Virus.
We have to change a lot of
Yeah.
policies.
But I mean, there's like
There's a lot of global stuff.
the
I didn't realize that. Like they have this. That's what they call it.
Yeah, exactly. That was an outstanding talk.
Oh, thank you.
That is a very
I'm glad I finished it in an hour.
Yeah.
But
Because John preceded me by several years.
When were you there?
93 to 94.
Yeah, I'm certain they lasted 4 hours. That's just not bad.
Yeah, well,
We missed
this
it.
is my second career. I mean, I was in a bank from 2004. Going out of school.
You look at the stock market, you're happy you gave the choice.
Exactly. Yeah, well, I don't know.
At least there's something to do for us.
Exactly.
Well, have a good day.
Yeah.
All right, good to meet you.
So, by the way, I just ran in this at the college meeting. Have you ever heard of Rich Rosenthal?
so if he asks,
Yeah.
Yeah, he's like,
The guy who did all that.
yeah, the digitoser and all that stuff.
Yeah, from Hopkins.
Yeah, oh yeah, you're interested in this too. He giving me a portable EVH. This is going on that it calls the hyperventilometer.
Oh, I see.
And
Yeah,
it's,
several companies.
I'm really excited. Yeah, I mean, because for me, just to have a scope, but also to because you're gonna keep a scope in very
You're challenging him?
yeah, and it could more closely